all the people. Great. Well, anyways, yes. So thank you all for coming, and thank you um, uh, for inviting us. Like Sung was saying, we've been interested in this stuff for a while, and totally interested in this community of other people who are interested in mobile apps and wearable devices. I think we connected like around 2014, 2015 when I moved to U of M. And Sung has been doing bone marrow transplant research and actually was very, very at the leading edge of developing a mobile app to help bone marrow transplant patients just navigate, going through what they go through in the hospital. And I have been really interested also in wearable sensors and early detection of disease and also in monitoring just overall health and well-being and so forth. And so let me see if now the slide is going to advance. Okay, there. Okay, well, anyways, so Sung is in the Department of Pediatrics as a professor in hematology, oncology, and bone marrow transplantation. I'm in the Department of Internal Medicine in the adult hematology oncology division. So we're both oncologists doing, mostly research. I also have these joint appointments in BME and the Center for Computational Medicine and Bioinformatics. And we wanted to have a kind of an overview slide to just let you know that we've been involved in lots of different projects. And we can't cover all of that. And we would love to, talk about a lot of these things. But I'll talk a little bit about like our work more in the hospital setting or in the patient setting together. And everything, basically, we've been doing everything together in a very kind of intertwined way, really, for these last 7 or 8 years. And so I'll talk about one of our studies where we used a non-invasive temperature sensor, and that'll be pretty quick. And then I think Sung will go into a study that we've been working on. Sung and I, and also a number of other PIs who will be mentioned, called the Student Resilience Study. It's a large study of undergraduates at the university involving both mobile app and Fitbit wearable device. And then Sung will also talk, I think, more about the Roadmap app, which is an app, which is actually the app that I alluded to that she developed initially to help bone marrow transplant patients, but then it's just really evolved into a positive psychology app that is, very, I think, can be really, really helpful for all populations. And so since we have time, if anyone has a question, like please do just speak up because I can't see everyone. So if you put your hand up, it may not show up, on the electronic thing, but just interrupt me. I'm totally good with that. So about this temperature project, I'm going to really kind of summarize it in just a few slides, but it kind of dates back to something that we have just been, just so, what's the right word for it? In a way, it's something that's so obvious, and at the same time, it's something that's so missing in clinical medicine. And so this is kind of like putting the doctor hats on. And when we look at clinical medicine, when we look at disease, if you look at all kinds of biology and kinetics and dynamics in any aspect of biology, I would really challenge anyone to look at this. I have yet to find something in biology that under certain conditions, at least, doesn't follow this kind of relationship of time versus activity. On the y-axis could be a biomarker, it could be the symptoms of a disease, it could be DNA melting, it could be anything. But basically, nothing really seems in biology and living systems to follow a linear course, right? It's always like this sigmoidal curve. I remember first being introduced to this in biochemistry class in undergraduate, the hemoglobin dissociation curve. But this sigmoidal curve applies to everything in biology as far as I can see. And what it really means, though, is that you have a lot of time when not too much is happening. Then you have some time when things are happening. And then you have a later time where a disease state is established or the process is established. If we look at it with respect to disease, you could look at this from many different diseases. There's a pre-disease state, like for diabetes, where nothing is happening. Then in the middle might be pre-diabetes, and the right side is an established state. you look at it from mental health, as I've learned recently, with affective disorders and depression, pre-disease state is, no clinical evidence. The transition state is maybe, initial episodes of major depression or the first crisis of mental health crisis. And then the disease state gets locked in, would be like treatment refractory depression, for example. So what we've been really interested in, and I'm just struck by, is that most of medicine is happening over here in disease state. Somebody gets diagnosed, with some established basically disease, and then we're trying to control it, to manage it, et cetera. This is definitely the case in cancer, but I think it's also the case in a lot of other diseases as well. And in most diseases, there are these transition states. That's our working hypothesis. And if we could catch those transition states and intervene earlier, then maybe we have a chance of actually reversing the process before it gets really established. So to me, that's sort of the conceptual, almost spiritual foundation, scientifically, for I think everything that for a lot of things at least that we've been working on. And so a very great opportunity to look at this presented itself through the phenomenon of fever and infection, in hospitalized patients. And this is where I'm going to totally summarize this and just say that fever, as probably everybody knows, right, is a very common sign of infection. It's not only a sign of infection, it's also a sign of any sort of big inflammation process that's going on, especially extreme inflammation processes going on in the body. And so there's a couple of big things, like one is bloodstream infections. The other is something called cytokine release syndrome or cytokine storm. That happens when people get really sick with COVID, with severe bacterial infections, also now with some new cancer therapies called CAR T-cell therapy. And so what we set out to do was to see, could we use wearable sensors to continuously monitor body temperature? And so instead of like picking up, these infections and cytokine release syndromes, once it's like really established, could we actually try to pick it up early? Because normally, these kind of measures aren't taken continuously. They're taken in the hospital like every 4 to 8 hours. And the idea would be then you can intervene early, again, and try to reverse the process instead of when you've got a full-blown, serious infection going on. And I'm going to do this in just a couple more slides, basically. And the big picture of it is we did this study together in these CAR T-cell therapy patients, 25 of them who can get this cytokine storm, and also in bone marrow transplant patients, also known as hematopoietic cell transplant. And they are very, very susceptible to serious infections because they're so immunocompromised. And we gave these patches to patients, actually had them self-administer them. They basically run 24 hours and they connect to your phone or to a central gateway device for transmitting data. And then we looked at electronic health record data as well. And in the interest of time, I'm not going to go through everything, but I'm just going to show you just a couple of examples. This is kind of what the data points actually look like. So the blue data here, so left to right is different days that they were in the hospital after getting their infusion of CAR T cells or bone marrow cells. And then the orange time points are the actual time points that the nurses collected a temperature, according to standard of care practices. And you can notice a couple of things. One is there's a lot of noisy data, but the other thing you can also notice is that there's this kind of up and down variation. The red line here is the fever threshold of 38 degrees. And you can see, like, obviously with more continuous data, you can actually capture much more information on that variation. Now, this plot isn't quite a great visual representation because these really low values down here are kind of overrepresented because up higher, there's a lot more data, except all the blue dots just overlap. But to make a long story short, what I would say is that we were able to carry out this study and we found a couple of things. One is we could definitely detect these events earlier, and actually a median of 18 hours earlier than the standard monitoring for infections. And then the other thing is we worked with Danny Forger's group and Jonathan Tyler and Caleb Mayer, who were in his group, and they did some circadian modeling of the body temperature. And what they found is that there are some metrics related to deviation from a person's own normal variation in their body temperature. And one of these metrics called difference in essentially the residual value beyond what you would predict from the model actually starts becoming noticeably different from baseline, even up to 12 hours earlier before the fever happens. Although not all of this is statistically significant, but you can see something is happening. So that gives an idea again into maybe we can catch these evolving processes like serious infections much, much earlier than when the patient gets really sick. And that's important because in these immunocompromised patients, even an hour or two of catching an infection earlier really can make a big difference in terms of the outcomes. So I will stop there and actually ask if anybody's got any questions before we kind of go to the next phase, which is a big switch of gears to quite a different study population.
Okay, yes, switching gears of study population, but with regards to sort of our global interest in using technology and mobile health to be able to detect events sooner than they would occur is hopefully a theme throughout each that threads all of our work together. So whether it's temperature sensors or Fitbit, Apple wearable sensors, to use digital phenotypes combined with patient-reported or other self-report mechanisms to use those data in combination to help identify patients at risk, whether it's for mental health or for fever or for other complications that our cancer patients go through. So in 2020, with the pandemic, it provided us an opportunity to actually use the mobile platforms that we were developing and actually provide it as an opportunity for students to potentially sort of benefit. We were interested in whether or not at the time, whether wearable sensors could provide digital signatures for detecting COVID. So that's sort of going back to March 2020, that's sort of where our interests were. We had this platform, which I'll go into if you can. I know, Manish, you're going to be advancing slides. We're going to talk about this platform. We're going to hopefully introduce this study that we embarked on. And if we have time, we'll get into this concept of compliance and wear time with wearables, but then we'll also give some results of this initial study that we had in 2020 and sort of catch you up to speed of where we are now in 2023 and where this project has gone and has sort of moved forward to. So maybe next slide. So as many of you on this call are aware, mental health on college campus, I think really it was climbing, but really sort of accelerated with the pandemic. And I think these numbers are probably dated now in terms of the diagnoses of mental health conditions in U.S. college students. Kristen Gilly, who's now a PhD student, she left to go to grad school. She presented this talk at the annual Depression on College campus last year. So some of this may be familiar, but the point of it is hopefully I can get you to where this study has led us to. So there's a lot of barriers to care, cost, time, stigma, availability, whereas mental health provides a tool for self-management, health monitoring, accessible, can be private, and can be used prior to or concurrent with other treatment strategies. And so, Manish, can you advance? Thanks. And so in 2020, we had this existing roadmap app that essentially we developed over 10 years. And I saw Elizabeth Hershey on this call with collaboration of CHCR, we developed the initial 1.0 version, which was iPad friendly, responsive on iPad only. This is back in 2014 when, iPads were just emerging in the market. And we developed Roadmap to really essentially serve as an educational tool for family caregivers. And through a series of interviews and getting user feedback, the family caregivers really wanted something beyond just an educational aid. And we started doing interviews and usability and a whole bunch of user sort of design analyses, and eventually started going into a framework of positive psychology and helping them adapt to this new life of cancer diagnosis, going through bone marrow transplant, and helping to support sort of their mental health and well-being. And so we developed what we call the Roadmap 2.0 version. And can you advance, please? And our initial population was family caregivers undergoing bone marrow transplant. We were developing it, testing it, ready to launch. And then, Manish, the pandemic began. We literally were about to embark in a randomized controlled trial in family caregivers, and the pandemic began. But then this also afforded us an opportunity to learn how to conduct this study essentially completely remote, do all of our recruitment remote and our onboarding. And we were about to do this in family caregivers of BMT patients, which we did eventually launch, but we also were able to eventually launch it in college students, given that the premise was this positive psychology platform that also integrated wearable sensors. So this platform, in addition to it offering a series of positive psychology-based activities, a chat forum where peer-to-peer can speak with one another, it also was a platform that connected with Fitness Tracker, that connected also with PROs. So we could send at whatever frequency we wanted surveys for our participants to take. So we could get some, I wouldn't say contextual data because it wasn't truly EMA, but we were able to get surveys at certain time points. And then we had this module called the resources that was purposely built so that we could swap out. So here you're seeing Family Caregivers Guide for Nutrition, Sleep, Physical Activity. Well, we could swap it out and provide resources for college students, for example. So when we launched this, what I'm going to be framing the most of this talk on is going to be geared towards college students. But we sort of really leverage this platform. One, if we could identify COVID risk factors from the wearables, get some PRO data. And to be honest, our initial intent was not so much to really focus on the resiliency, the positive activity. If they used it, great. We're going to go back and study those processes. But our initial intent was really related to COVID and leveraging the Fitness Tracker, the daily mood, and their surveys. And so next slide. And so here was our study design. We basically recruited U of M college students, and we sent out a target email. The next slide will show a consort diagram of how many emails it reached and eventually who our study population was. Oh, I may have deleted it, but basically we sent out a target email. We also posted flyers. And then students contacted us through email. We onboarded them through Zoom and other forms of teleconference. We had them download the Roadmap app, and they also downloaded Danny Forger's Social Rhythms app as well. And then they also downloaded, of course, the Fitbit app as well. And then they were instructed to take monthly surveys throughout the semester, basically a baseline, month 1, month 2, month 3, and then an exit survey. And then next slide. Here are the participants. I must have removed the consort flow diagram. So the initial email targeted around 40,000 students. We essentially ended up getting over 2,000 enrolled. We did not realize when we sent out such an email, I mean, literally, it was just watching the ticker go off like within a half hour, we had hundreds of students enrolled, and it was very hard for us to be able to handle that load. But in fact, it actually crashed our HITS server, where it couldn't handle all the students onboarding at the time. Here were the demographics of the students. On the left is the published U of M student demographics, and then on the right is what our study enrolled. About 58% Caucasian, 30% Asian. It was a little higher than the U of M population, which we found interesting. African American right on target. The rest were sort of on target with the U of M population as a whole. Okay, next slide. Oh, here it is. So this was the consort diagram. So the recruitment email went out to about 48,000 students. Our team assessed for eligibility that you're a currently enrolled U of M student. We had students where we mailed out Fitbits and everywhere to California, everywhere except internationally. But if you were within the United States, we allowed you to be enrolled, because at the time, students necessarily did not have to be on campus to be registered to be a student because of the COVID situation. And so we assessed around 3,100 students. We excluded 600 because they did not meet criteria, or they eventually, as we got into the process, declined. We consented around 2,500, and in the end, our final population was around 2,164. And we basically ended up analyzing a little under 2,000. In that population, in the fall of 2020, we identified about 178 COVID positive students, and then the rest were negative just during that period. And it was the most sort of strict quarantine times we had probably throughout the period. And Manish, can you advance? Mm-hmm. I'm going to skip over compliance in the interest of time if we have time. Essentially, this topic was, what data do we count of their Fitbit? Is it if we just measure a single heartbeat, or did the student have to wear it at least 6 hours a day or 8 hours a day, or did they have to have a minimum number of steps? So we didn't know where to begin. And so we had a talented sort of grad student in engineering who went through the process and analyzed the 2,000 over a 4-month period of time, a definition of what compliance was going to be. So why don't, in the last bit of slides, go to the results, and we can talk about where the study is currently. We wanted to look at factors that contributed to COVID risk based on the self-report as well as digital markers, look at the mental health landscape through self-report, and what sort of the platform for mHealth in supporting college students and where we're at with it. All right. Okay, here are the initial measures we looked at in 2020. In 2021 and 2022, we increased the many different survey instruments were added, but here were our initial ones that we looked at. We looked at anxiety, passion and flourishing. This was with our collaborator, who's a psychologist at the business school. Loneliness, a brief COPE measure, a belief in public health, and then we added the PHQ and GAD a little bit later in the study. So we didn't get really robust numbers and people who answered that until really the month 1 survey. Okay, thanks. And so we built a multivariate model that included all the variables significant in the univariate analysis. So we included race, grade, so that means year in schooling, freshman, sophomore, undergrad, grad, substance use, their self-report substance use, a coping measure, loneliness measure, and then student social fit. And what we found increased the risks of developing COVID were those who expressed lower belief in public health measures related to COVID in advance, and then those who reported increased consumption of alcohol and or marijuana use. And the third risk factor was those who lived with greater than 20 roommates, usually in some sort of large house that they shared, or sorority or fraternity type of housing. Okay. Advance. This is just a slide to note that Danny and his students looked at circadian rhythms and essentially looked at basal heart rate and some other measures of their circadian rhythm algorithms, and found that basal heart rate increased around COVID-19 symptom onset. And so they took the 2,000 plus students, and we published in this journal that these heart rate parameters prior to developing COVID was associated with, I wouldn't use the word, I'm trying to be careful with the word prediction, but there were associations of heart rate changes prior to developing COVID that basically were markers of essentially developing future COVID. Okay, next slide. I think what was striking in the self-report data that we received through the Roadmap platform is that about 20% reported mental illness, close to 38% anxiety, and around 33% that reported anxiety, depression, PTSD, or other. The baseline anxiety self-report survey that they took, 24% reported moderate anxiety, and up to 49% reported high anxiety. So Manish, maybe you can just go through, I think it kind of comes in. We looked at, did it?
Oh, just this one right here?
Yeah.
Oh, advanced one more, sure.
Yeah. So basically, just to walk you through this, we looked at depression as the outcome, anxiety, and flourishing, and loneliness. And essentially, male sex was associated with lower depression and anxiety and increased flourishing and loneliness compared with female sex. And African American was associated with increased depression and increased loneliness compared with Caucasian as a reference group. Asians had decreased anxiety and increased flourishing and decreased loneliness. If you were an international student, you reported decreased anxiety and increased flourishing. And then undergraduate students compared with graduate students had increased depression or decreased flourishing. And then if you were a second generation student, you reported less depression, less anxiety, and improved flourishing. So we felt, those were quite interesting. We are sort of following up on some of those factors, but this was back in 2020. Okay. And this is just a slide to show. So we asked daily mood on a scale of 1 through 10 through the app. And it's anchored by best possible 10 and worst possible mood of 1 to 10. And this slide is essentially showing that the daily mood scores leading up to when they took the PHQ or the GAD, there seems to be an association of mood scores correlating with your level of PHQ or GAD. So lower mood scores associated with worse PHQ, worse GAD. Hope that makes sense. So can we use a daily marker to sort of correlate or associate with future sort of the typical time point of when we may do a snapshot sort of PHQ or GAD? Okay, next slide. We then looked at the relationship between sleep and mood, and the next slide shows steps and mood. And you can really see the close association with the sleep and mood. We have not looked at, is it the sleep before, the day before, 2 days before, a week before, but clearly there seems to be an association with the sleep you got and the mood that you reported. The steps, there was less association. Okay, next slide. Kristen, who's now in grad school, starting to look at these analyses. We're starting to get into app usage, what students used what, how did it correlate or associate with their mood or how they reported on the surveys. The most commonly used activities were, I know we didn't have time to get into each of the positive activities, were the positive piggy bank, the gratitude journaling, and the pleasant activity scheduling, followed by savoring. And so it's interesting because the cancer population they had different top usage of the positive activities, but for the students, those were the top ones used. And the next slide. One of the activities has something to do with taking a photo, either savoring it or making some notes about it. And so Kristen and Michelle and some of our students are starting to analyze all the different photos that they've taken. They're using a tool called Amazon Rekognition. And then there's 2 independent coders to either agree or not agree with this Amazon. Is kind of like an AI tool, and whether or not they agree with it. And they've started analyzing this and looking at what the top photos were taken during that time. Okay, and then next slide. Where are we? And in the last minute, this is where I'm sort of going to wrap up this talk. So this was in 2020. We then conducted a very similar study in 2021 in the fall. We reached out to the same group of students, so that was close to around 2,000 initially. We had around 1,100 who were interested in participating the following year, and you can see sort of the robust sort of responses that we've made with the surveys that they've answered at each of the time points. So we've gotten a pretty engaged group of students doing it. We repeated this study in 2022, and we got similar numbers of participants and feedback. I know I had to cut a lot of slides, Manish. So, and then most recently, so the study essentially began in 2020. We repeated it in 2021. We repeated it again in 2022. And then in the fall semester, which in the winter semester right now, we've had amazing collaborators at Wolverine Wellness who have partnered with us and essentially doing a study where it's app plus human coaching. And it's essentially a partnership of, because a lot of the coaching strategies that they use are based on resilience and positive sort of psychology based activities. They're sort of reinforcing the activities that are within the app itself. And so we've had about, we just started this project, and I heard this morning we've had around 21 students who have signed up to do the app plus human coaching. And so that's where we are with this student COVID study that we've now sort of morphed into calling the student wellness study. And so can we advance to the, these ideas all really came out of this Ideas Lab team that came together through the Biosciences Initiative. And so Kira at the ISR, Natalie Kolbianki, who's at Kinesiology, Ron Zernicki, oh, maybe it's in our acknowledgement slide, but Ron Zernicki also in kinesiology, Mosheroff in engineering, Stephen in engineering, Joel, who's in kinesiology, orthopedic surgery, and Julia Lee Cunningham at the School of Business. She's a psychologist. And so I think that actually gets us to our, the sort of take home wrapper up slide is that mHealth has been a great platform because it's scalable, accessible. Hopefully we showed that here. It can be used concurrently with other treatment strategies, as we're learning with the human coaching, can be private for those who want a little bit more anonymity to their use of mental health, mHealth strategies. And it can also be, hopefully, essentially, we can get to a more personalized, adaptive type of platform with the work we've been doing. And so with that, I think our last slide hopefully takes us to, maybe we can just advance to acknowledgements, Manish. Just Manisha's lab, our lab who started this in 2020, and the Ideas Lab and the funding that has come through the biosciences, the Taubman Institute, and Danny's lab and his collaboration with the wearables. It's just been a wonderful collaboration with these different groups. And so maybe with that, I'll stop. I know we went a little bit over, but hopefully we have some time for questions and further discussion.
Thank you so much. Yeah, so that was awesome. I have a lot of questions, but I'd like to open it up to others to ask questions. Feel free to jump in, or if you want to put them in your chat, in the chat, I can read them either way.
I have a question. My name is Grace. I'm from the School of Nursing. I'm also an oncology nurse. Worked in BMT, and then I also teach students at the School of Nursing. So this was an amazing talk, very interesting. Thank you guys so much. I actually have multiple questions as well, but I'll try and choose one to start. For the student study that you did you look at the students' major, particularly looking at like health sciences students versus LS&A versus engineering, et cetera?
So Grace, that's a great question. So initially, when we designed it, the answer is no, but we amended our study, and now we have access to their GPA, their majors, their everything. And so we're going to be doing those analyses. We had to amend the protocol and then get reconsent for the students to be able to agree. So we don't have the full 2,000 because it wasn't initially, but we did get a pretty decent number of students when we reconsented for that, who agreed to give us GPA. And with that, it gives us their major and things like that. But we were amazed at how many students who were willing to actually provide, that's pretty personal data, and they were really willing to provide permission to give us access to all of their records.
That'll be very interesting to see. I think that's something that, especially in the middle of a pandemic, you know, students doing their clinicals and just where they're at. I'm very interested in that data, so I hope to see it soon. Maybe I'll let others ask questions, but I've got a few others.
We have a couple of questions in the chat, and the first one is in regard to the first study. How do you anticipate the information about infection prediction being applied in clinical settings?
Did I answer that one, Sung, or?
You're going to answer it, or do you want me to answer?
I'm just asking whichever one.
Oh, no, go right ahead. Yeah.
Yeah. So I think there's a couple of settings. So one is, this is not standard of care right now in the hospital. So our study was in the hospital, and already in the hospital, we could see this even without even getting to prediction, just earlier detection of the events. So, you know, one of the very straightforward implementations you would think would be to apply it just in the hospital to, you know, bring it into standard of care. And so we've been working on like actually potentially designing a clinical trial to actually, you know, test, does it reduce the number of really the outcomes, right, of bad infections and so forth. But what turns out, though, is that to really implement something in the hospital is actually a much higher barrier than to implement it at home. And we also believe that probably the biggest impact is actually going to be with patients using this at home, because, you know, we showed you some examples of CAR T patients and stem cell transplant patients, but they're the minority of cancer patients that stay in the hospital for their treatment. Most cancer patients get treatments and then they go home, like chemotherapy very commonly. And then they're at risk for infection at home. So I think, you know, we think that the real impact of this, and probably the fastest impact, is going to be in actually using these devices at home. And so that's where, you know, we've been working on, you know, trying to come up with a project and really write a grant to do a clinical trial, especially in the outpatient setting. And the other thing I'll just briefly mention is in pediatrics, actually there was a pediatric hem-onc fellow, you know, that worked with us, and he did a case series essentially of just like how this was used by the patient's caregivers, basically by their parents, because we were just putting this in also in the outpatient setting, just as an observational thing. But there were actually two cases in which the device said, "Oh, patient has a fever." The thermometer said no, and the parent called the hospital and said, "Hey, there's a problem here. The device is saying there's a fever, but the thermometer says there isn't." And basically they said, recheck it with the thermometer, and there was no fever according to the thermometer. And they said, okay, well, the device is this is just a research study. So, you know, just keep monitoring. And then the next morning, you know, the parent calls again and they said, okay, since you're concerned, just come in. And in both of those cases, the patient was was really sick, actually, with a bloodstream infection, life-threatening, hypotensive, you know. So anyways, there were a couple of anecdotes to show, I think, that it really can have that impact. And then, I don't know, Sam, do you want to look at 2 and 3, the questions?
Well, I kind of want to switch. Somebody else jumped in with question about the compliance and like how you defined what protocol you came up for usage. And I would love to hear that.
Perfect. So Sung, do you want to walk through those slides? I can pull them up.
Yeah, I was just looking for them, but I forgot you had them.
Yeah.
Yes. So yes,
I'll
we
share the
can
screen momentarily.
we put them at the end, right?
Yep.
Okay.
So, here, let me just share my screen here, and then I'll put these compliance slides. Share screen.
And so Lubna is actually, so I think the take home message is she did this initial analyses, which I'm about to show you on college students. She then took, we got data sets from our caregiver population, both oncology and bone marrow transplant. She got another 2 different caregiver populations, because the question was, can you apply what she eventually developed as her algorithm just uniformly, or is it population specific? And not surprisingly, it's pretty population dependent, meaning college students have different activities compared with, for example, a family caregiver going through bone marrow transplant with a patient who has cancer. And so her question was, you know, what is a required amount of data that you need to consider including for your analyses? What exactly is a valid Fitbit day was essentially the question. And then next slide. Should we, you know, do it based on the number of steps a person has? Do we count X number of steps, or do we count how much they actually wore the Fitbit based on what parameter? And so we ended up choosing heart rate because the Fitbit gives us seconds level data on the heart rate. So rather than using steps or sleep or other activity parameter, we as a group decided on the heart rate. And so this is just getting back to, you know, step count, like why should we do it? Not. So eventually she just basically plotted all of our data, all of our participants, and where did they fall? Where did the majority fall wearing it most of the time based on heart rate? And you can see that over 50% were wearing it for more than 16 hours. So we were like, wow, these college students are actually pretty compliant in wearing this Fitbit. I mean, we didn't really say you have to do it all the time, every time. We didn't pay them to do it. They just happened to wear the Fitbit. More than 50% of them wore it for more than 16 hours a day. Okay, next slide. And so we decided to go based on this sort of wear time as opposed to the steps. Okay, next slide. Basically, she then plotted out between 8 a.m. So then the next question began, when do college students actually sleep? Because, you know, how do we count the heart rate during the day versus the night? What do we do with the nighttime? And so she came up with these cutoff parameters. Okay, 8 a.m. to 8 p.m. What is the step count of the population during the average step count of the population during that period of time? And she eventually did the same thing with sleep. And can you advance? Are there some markers here? Yeah. So what she found that this cutoff of 6 hours between 8A, 8P pretty much gave where the majority of the students were wearing it and where their step count sort of fell off right around a similar time point. So that's where she came up with the 6 hour cutoff during the day for activity. And then at night, it seemed like for the most of the students, you know, this was during COVID, it was probably during the most, like, you know, given it was quarantine, that students weren't doing much like they normally would, and they were not as active. As you could see, our average step count during that period is around 6,000, and I can tell you now in 2022, when we just analyzed the data, it's back up to the 16,000 range. So we did do that analysis, but getting back to the data, the average sleep was right around 7 hours between 8P and 8A. And we did not put any threshold of how many hours that they had to sleep. We just counted what the Fitbit basically gave us. I think that's all the slides I have. She did essentially the same analysis on family caregivers of cancer and BMT, on another family caregiver population, I think of Huntington's disease, Alzheimer, and we did it on patient populations, and they all sort of varied these thresholds. So and this paper is about to be published, and basically her take-home message is, you have to do these types of things based on your population and their activity level. And so that is sort of the take-home message we got from doing all the different Fitbit analyses from these different population sets.
Well, I know the questions always can go on for so long. I just want to recognize that we're 2 minutes over time, and I am personally late for another meeting, but Danielle is able to stay on a little bit longer, but I wanted to check in and see with Sung and Manish, are you able to stay on, or do you want to, do you need to move on?
I'm able to stay on, so happy to take further questions, or please, I mean, my email, Manisha's email, please feel free to reach out to us. I know I've emailed many I see on this call for different advice or thoughts or input, so feel free to email.
Awesome. Well, I'm going to sign off and turn it over to Danielle. Thank you so much. This was an amazing talk, and I hope to see you again soon.
Hey, Victoria.
Thank you. Is there anyone that has another question that they'd like to ask? As they said, you can also, of course, email them.
Just had a quick question.
Yeah,
just wondering what kind of Fitbit devices you selected and why those specific devices?
So back in 2020, we used Fitbit Charge 3. Why? Because we got a really good university deal on it, and Srijan with Intern Health, he had good experience using it, so we just sort of took his lead and used Charge 3. But Gabriel, we've used now Charge 5. It's compatible with all the Fitbit. Once you have their API, you can use it with all of their devices. And Manish and I have tested out their Versa 2 on it. So it's Fitbit agnostic in terms of what device you need to select.
Thank you.
Any other questions?
I see, Gabrielle, you had the question of Fitbit data correlating the timing of the mood or any of that. We haven't looked at that yet. Yeah.
Yes, there was another presentation before that talked about, I think it was like the activity days. Like if they had low activity, they wouldn't respond to the mood questions either.
Yeah.
That's why I was curious about that.
Yeah, it's kind of in process. Yeah. Yeah.
Okay, well, thank you again so much. Really interesting talk, and looking forward to hearing more about your progress on different studies. So
thank you so much.
Thank you.
Yep.
Bye-bye.
Thanks,
everybody.
Michelle, for joining. Good seeing you.